Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Christopher Syed. He's a dermatologist. His KevinMD article is titled, "Why Does It Take 10 Years to Diagnose This Common Disease?" Christopher, welcome to the show.
Thanks so much for having me.
So we'll get into your article in a little bit, but first off, just briefly share your story and journey to where you are today.
Sure. So I did all my training at University of North Carolina, and I'm on the faculty there. I've been there for about 10 years. And, during training, hidradenitis patients were always some of the toughest to manage. And it always felt like they left, and I didn't have that much confidence that they were likely to get that much better. And I think the patients felt that a lot of times too. So it felt like there was this huge need to try to learn some new tricks to try to do better for those patients. And so it really made me push myself to learn more about better ways to treat them, to learn about how to do surgical procedures in the clinic, and to expand what we could offer for them to make a better difference for them.
So why did you have such a specialized interest into hidradenitis?
Yeah, mostly it was just, seeing where the need was the greatest. I think we all get into medicine to try to help patients. And when we see patients that struggle, I remember in medical school learning like, the frustrated patient makes for a frustrated doctor, right? Like, and those were frustrating experiences because those patients just didn't get better most of the time, or at least as well as I wanted them to do. And so it was really just seeing where, there were lots of people out there doing psoriasis and other things like that. And those things were easier to manage, easier to find specialists in those things. Nobody was really focusing on HS. And it felt like this huge unmet need. So it was, intimidating starting off, but it felt like it's paid off because I feel like there's more we can do for those patients, and getting out there and teaching others about it, getting the dermatology community more up to speed has been a fun journey so far.
All right. And you talk more about that in your KevinMD article titled, "Why Does It Take 10 Years to Diagnose This Common Disease," being hidradenitis suppurativa. And for those who aren't clinicians, aren't familiar with this condition, just give us a little bit of background and context as to what that is.
Sure, it's surprising that the general public doesn't have more of a grasp on it because it is such a common disease and it's really miserable. I mean, patients basically get like these painful nodules or abscesses. Some people refer to them as like boils that will get painful over the course of a couple of weeks. They'll often open up and drain and kind of leak pus and blood. It's often in places like the underarms and groin. So since it's hidden and out of sight, it's something that I think, patients don't want to have to bring it up a lot of times too and talk about it. So even within families, a lot of patients haven't told their family members about what's going on, or it takes them years to sort of come out and really say much about it. And so since it's hidden and out of sight and there's so much stigma around, having chronic wounds in areas like that, it just doesn't get talked about very much. But it has, as you can imagine, it comes up in the teen years, early 20s most commonly. Like that is such a tough thing to deal with and to explain to other people in social aspects, whether it's romantic or just even friendly relationship, what's going on. And so yeah, it's a huge challenge for those patients, and worse than almost any other dermatologic disease. We talk about psoriasis and eczema. People have a general sense of what those things are. They've never heard of HS, even though it's also very common and probably much worse to live with than those other things.
And what are some of the general causes of this condition?
So about 50% of patients have a family history. And so we know that genetics play a large role. We're just kind of getting to the point of doing some large genetic studies that are trying to identify some of the genes that might predispose, but definitely tends to run in families to some extent. And then I think just like with other chronic inflammatory conditions like psoriasis or Crohn's disease, rheumatoid arthritis, there are aspects we don't understand, right? There's probably some environmental triggers that are out there too. It's a mixture of the right genetic predisposition plus something else in the world, or just some randomness to it because our immune systems interact with the outside world and things can get triggered the wrong way sometimes. So I wish I could answer that because patients want to know all the time, like, why me? Why now? And I say, just like those other chronic inflammatory conditions, it's hard for me to tell you why exactly it happened the way that it is, but much more akin to things like, Crohn's and rheumatoid arthritis than to infection. It looks like infection. It's the body mimicking a response to infection. So it gets misdiagnosed as a staph infection or things like that all the time. But really, it's much closer to a type of chronic inflammatory disease that affects hair follicles where they just get inflamed and that response is mimicked.
And what are some typical case studies of patients that you may see in your clinic who come to you for HS?
Sure. I mean, just like with other things, it can vary. I mean, sometimes the onset is explosive and very rapidly patients have, terrible disease that has tons of scarring, everyday drainage where they're having to bandage themselves for 30 minutes just to leave the house. But a lot of cases, again, it starts, mid-teens with an occasional kind of small nodule. People think it's just a bump from shaving, or maybe it's just a little infected hair follicle. But then it goes on and on like that over and over again over the course of years. And then finally, they hopefully get diagnosed. And the title of the article mentions it takes 10 years on average to diagnose it. And that's not like historical data. That is data from like a big global study back just a few years ago. where people should be able to Google, I'm getting boils, and they get HS is going to pop up as the likely diagnosis. But even still, I think it's, patients don't always connect the dots, and they've been told the wrong thing a lot of times, so they don't go hunting for an answer at that point sometimes, and they're just hesitant to like keep going to the medical community over and over again if they're not getting clear answers over and over again. So yeah, it's frustrating that it takes that long, but that's often what I see is patients were misdiagnosed for years. It got worse and worse. Finally, they get identified or referred to me, and then we try to work on treatment from there, which is more difficult because it's gotten so much more advanced over the years.
So talk more about your article in terms of it taking so long for it to diagnose. So what are some typical reasons why that is? What are some common misdiagnoses before these patients come to you?
Sure, it's definitely multifactorial. I mean, again, there is this like stigma that occurs, and that means patients often hide. So sometimes that first couple of years is patients being sort of unwilling or not wanting to have to sort of go and talk to a medical person and have their body looked at against a young patient who hasn't done a lot of medical stuff usually. And so some of it's that, and just sort of hiding and embarrassment to some extent, because even with their family members, they haven't told them about the symptoms they're having sometimes for a while. But then they show up and they've got one nodule they kind of point out is just miserable to the point they've had to go and get it drained. And so somebody just sees that one spot and says, looks like maybe you've got a staph infection. They drain it or give an antibiotic. And then a year or two can go by maybe before the next one when it's early in the disease. And so it can be confusing those first couple of years. But after a while, it's like when it's happening over and over again, it should be getting recognized. And there's this, I think it's an issue in the medical community. Like, I started teaching our medical student course for dermatology years ago, and there was no mention of hidradenitis, right? We spent 45 minutes on psoriasis and 20 minutes on rosacea, and HS was not mentioned anywhere. And it was really, an injustice to like the patients that this disease affects that didn't get mentioned more often. I think part of it was people who made those curricula just, they didn't have clinical interest in HS, they had clinical interest in other things. And so what made it to the curriculum did not reflect what was happening in the real world, I think. And so part of it's that medical students could get through their training and, never see a case of HS, or more likely they'd see a case of HS, but they were told the wrong thing. Like they were exposed in the ED, they thought it was an infection, they got treated a certain way, and they just didn't know that this entity existed. And when it was mentioned, it was kind of, obscure. It's got this like funny sounding name. And I think people were kind of confused or intimidated by it to some extent. But really, like, I always try to drive the point home, like, it is not a complicated diagnosis. Like, if people have typical lesions, abscesses, or nodules that are painful in places like the groin and underarms, and if it's recurrent, like, that's HS. Like, nothing else really mimics that. So even a one-time, nodule or abscess in those classic locations should prompt a question like, has it happened before? Has it happened in places like the underarm? Or, if it's in the underarm, has it happened in the groin? Because patients will tell you what's in their underarm. They might not mention at all the fact that they've had 5 other things like that in the groin before, because again, there's this sort of stigma and embarrassment, and they're not prompted and asked about it specifically.
So take us into your exam room. So I'm a primary care physician. Let's say I send one of my patients to you for suspected HS. Tell us, how would you work up this patient, and what would you do next?
Yes, I mean, there's not much of a diagnostic workup needed. I mean, it's all clinical in terms of diagnosis. It's, recurrent lesions, classic locations over time. I don't need to do lab testing typically. Like, we know these patients do have a high rate of things like diabetes and dyslipidemia. Like, their rate of cardiovascular mortality is twofold compared to patients without HS. And so I do screen for diabetes sometimes. I mention those things to patients, try to make sure that with their primary doctor, they are getting screened for other things like that. And then things like, there's a lot of issues with anxiety and depression in these patients also. A lot of that's linked to their disease. And so those are conversations I try to bring up at some point also to make sure they're coping okay with their disease. But the number one thing they want is to feel better. And so I spend a couple of minutes of time, a couple minutes for every patient, kind of just, again, reframing the disease, because they've often heard the wrong thing. They've been screened for STDs. So I tell them, what you have is not contagious. This is a chronic inflammatory condition, just like if you had rheumatoid arthritis in your joints, it just comes up around hair follicles instead. And it's not something where there's infection. Like, we treat with antibiotics, not because we think it's infected, but because your body probably overreacts to even normal skin bacteria. And so we're trying to change those things. So it's really important to reframe the disease in their mind early on as this chronic inflammatory condition, as opposed to just infection or something where, again, as much as I know it's not contagious, and I think most of us know it's not, like, they don't know that until they're told. And so I think for them, it's very sort of, heartening to hear those things out loud from a medical professional. So I do always a couple of minutes of education, and then I try to dovetail pretty quickly into, okay, this is how we're going to manage it based on what we know. And if it's, just bumps that come and go from time to time. We try to use medications mostly, or sometimes things like a hair removal laser if it's in areas like the underarm and groin. When it's more of the tunneling and scarring that's happened over time, that's where we think about biologics like, Humira is a FDA approved for HS. There's others that will likely be approved over the next couple of years that are just anti-inflammatory biologics. And surgery is a big part of it too, where once those tunnels and scars develop, we often need to do procedures to address those areas where the medicines get it calm, but it's just like rheumatoid arthritis, right? If a joint has been destroyed and or this remodeling has happened, sure, you can control the disease and the inflammation with medicines, but you got to repair that damage that's been done. And then you have to maintain that improvement over time by continuing medication. So for the worst patients, it's a marriage of good medical management to stabilize and calm things down, surgical management for those areas that are going to be recalcitrant, and then hopefully maintaining that improvement as time goes on.
So from a primary care setting, so if I see a patient with suspected HS, talk about some of the initial treatment options that I have. So you mentioned counseling, which is something that certainly will do. How about if we take the next step in terms of initial management, in terms of what to prescribe?
Absolutely. So, and again, some of that depends on how severe the disease is. But yeah, early on, there's lots of topical therapies that get used, like topical clindamycin, or some people use chlorhexidine washes or benzoyl peroxide washes. That's often a very small part of the solution, but it's easy enough to add those things on. Can antibiotics work because they probably alter the microbiome in some way rather than being, truly treating infection? So, a week of an antibiotic maybe helps for a flare up. And if a patient flares up just a few times a year, I often make sure they've got an antibiotic on hand, and there is no great evidence that says one antibiotic is better than the other, but most of the time, the easiest ones to start with are things like clindamycin, 300 milligrams twice a day, doxycycline or minocycline, 100 milligrams twice a day. But I've seen plenty of patients respond okay to Bactrim or lots of other antibiotics. For some patients, they say when I'm on the antibiotic, I'm good. When I'm off, I'm really bad, and it always falls apart quickly. And I think there are instances where longer term antibiotics, whether it's a few months or even just suppressive, just like we do for patients who have been transplanted and have, bad immunosuppression, or they've had recurrent cellulitis, we use, prophylactic antibiotics to suppress things a lot of times. Or like, again, another good example is ocular rosacea. Like those patients are often on minocycline or doxycycline for life. And so not every patient needs that, but if it has a huge positive impact on quality of life, I think longer term suppressive antibiotics like that, the benefits can outweigh drawbacks sometimes. And for female patients, oral, like combination oral contraceptive pills, things like spironolactone that block how hormones affect follicles some, just like for acne, can also be very helpful sometimes. And so those are often, longer term ways to try to control things. So those, and then metformin has a little bit of evidence too, probably because a lot of these patients have PCOS and or sort of have impaired fasting glucose at least, and many of them are diabetic. So metformin seems to play a positive role for some. It could just be harder to tolerate with the stomach upset sometimes. So those are all relatively straightforward ways, to manage things. Even medicines like adalimumab are not, that much riskier, I feel like, than a lot of the drugs that most primary care doctors use. And I know there's a big problem with dermatologists not always being accessible to patients. So I often say, like, if a primary care doctor feels comfortable using those medicines, I don't feel like it's off limits when a patient really needs it. Because really, it's like a TB test once a year. They have signs of infection. You tell them to stop and hold a dose. But for primary care physicians prescribing short-acting insulin, like there are way more patients ended up in the hospital having bad side effects from something like that than something like adalimumab. So again, I think when the situation calls for it, it's, takes a little reading, just feeling confident about it. But I think sometimes it's, you do what you got to do for the patient.
And what kind of scenarios should we consider referral to a dermatologist?
Yeah, I think, patients already have, a fair bit of scarring and tunneling. That by itself is a decent indication because that patient qualifies for a biologic therapy most of the time, whether it's adalimumab or off-label things like infliximab or secukinumab, which will likely be approved soon. So that's where I'm really thinking about how to slow the disease down and not have to play catch up because they've all of a sudden got, twice the amount of scarring and tunneling waiting another year or two. So that by itself makes it very reasonable. Or if, some of those initial management steps just haven't calmed things down well enough, that can also be a reasonable time to go ahead and sort of send them on if it feels like you're at the limits of what you feel comfortable doing, basically. But yeah, I'd much rather get a patient early and try to stop them from regressing as much than to have to play catch up when they've, already had all the scarring and tunneling. And I know they're going to need a bunch of surgery at that point. And my goal with medicine and early intervention is to limit how much surgery the patients need. Because that, patients who get stuck doing, 5, 10, 15 surgical procedures over time, that's just as bad as having a chronic disease. So I'm trying to limit that whenever I can.
So you're a dermatologist who focuses on HS. How common actually is that?
So that's been up for debate some. There are old reports that put it as high as 4%, but those were sort of very biased populations that were being looked at. Some of the best studies, If you just look at ICD-10 codes and systems, put it at about 1 in 1,000 patients, which is not uncommon at all. A lot of the studies that have done survey-based studies asking patients, like across large populations, just have you had recurrent, abscesses or nodules in places like underarm and groin, that puts it as high as like 1% in some studies, or 1.2% even, kind of looking at different methods of really assessing how much it's actually out there, because it gets misdiagnosed. And so the ICD codes just don't exist in the system. So, and that's across, Europe and North America. And there have been some similar studies done now in a couple of other countries and like Africa and in South America, where it's probably not that dissimilar actually. And so, yeah, if you're talking about a disease that's 1 in 100 to 1 in 1,000 people, that is not a rare condition the way that it used to be thought of 20 years ago, when I think we just weren't recognizing it.
And my final question, what are some of your take-home messages that you want to leave with the KevinMD audience?
Yeah, I mean, I think my biggest one is that, the misdiagnosis that happens and sort of, that lack of counseling early for patients is harmful, because the longer patients go without diagnosis, the worse they are by the time they actually get to good management that slows their disease down. And so, again, like simple diagnostic criteria, recurrent abscesses and nodules in typical locations like underarm, groin, buttocks, like HS until proven otherwise, right? So that should come to your mind first and foremost. Like there's no complicated, diagnostic workup to be done beyond that to make that diagnosis and start to mention it to a patient and try to set them on the right path. So that's my number one take home point.
Christopher, thank you so much for sharing your time and insight, and thanks again for being on the show.
Happy to do it. Thanks so much for having me and bringing awareness to HS. It needs it.